Good morning and welcome to this second session of reproductive system pharmacology. In this second session, we will focus on the pharmacological actions of estrogen. We shall review the biosynthesis of estrogen, its pharmacokinetics, its clinical applications, and its adverse effects. If there is one molecule that you can think about that represents femininity, then that hormone is estrogen. Estrogen is responsible, for example, some of the mood swings that we might see in the females. Sometimes it is well behaved, and sometimes it has really some bad behavior. We shall review some of these effects of estrogen in this lecture. Estrogens may be spelled, sometimes is spelled without an O at the beginning. And in some books, you'll see it spelled with OE. So typically the OE is the British or the UK spelling, while in most American books, the spelling is with an E. So by the end of this session, you should be able to list the natural and synthetic estrogens available for clinical use, should be able to outline biosynthesis of estrogen, explain the mechanism of action of estrogens, describe the effects of estrogens on different body systems, should be able to describe the main features of the pharmacokinetics of estrogens, outline the clinical uses and contraindications of estrogen, and also explain the benefits and also adverse effects of post-menopausal estrogen therapy. So if you are not already conversant with some of these areas, then this lecture is for you. So one of the questions you should be able to answer at the end of this session is, for example, the question that's given here: a young adolescent female diagnosed with hypogonadotropic hypogonadism is receiving hormone replacement therapy. Which of the following is a likely effect of the hormone replacement therapy? A, increased serum LDL. B, low bone mass. C, acceleration of epiphyseal fusion. D, suppression of breast development. E, hot flashes. So if you don't already know the answer to this question, at the end of this session, we look at what is the answer. So estrogenic activity occurs in a variety of compounds. We can classify estrogenic compounds as one, natural estrogenic compounds, and two, synthetic estrogenic compounds. The natural estrogenic compounds may be further be classified into one, human, the endogenous estrogenic compounds that are found in the humans, and these are mainly three. You see them there in column 1 of the panel. These are estrone, estradiol, and estriol. The most potent of this is estradiol. The other sources of natural estrogenic compounds is commonly the equines, particularly the horses, and the estrogens that you find in horses include equilin, dihydroequilin. The estrogens from horses are still very important in clinical use. So a preparation, for example, Primarin, is conjugated estrogens, and that conjugated estrogens is obtained from the urine of a pregnant mare. Other natural estrogens are also called phytoestrogens because their origin is plants, and many of them are isoflavones and also cumestans. Some examples of the phytoestrogens are given there, especially the isoflavones such as genistein, daidzein, and interlactone. You get these phytoestrogens in very many common foods. So for example, in soya beans, in the peas, in the lentils. So you get lots of the phytoestrogens in some of the foods we consume. The others, as I've indicated, are synthetic estrogenic compounds. And you may subclassify these again into steroidal synthetic estrogens and non-steroidal synthetic estrogens. The steroidal synthetic estrogens are also very popular. They are among the most common estrogens that are prescribed in clinical use and are found in many of the hormonal contraceptives. An example is ethinyl estradiol, which is the first one there. You also have mestranol and quinestrol. The non-steroidal estrogenic compounds that have been used quite a lot in the past include diethyl stilbestrol, but which currently is not used, for example, for contraception because of some serious adverse effects. It was found that those females who had used diethyl stilbestrol, for example, as a contraceptive, had female children who had a high risk of vaginal adenocarcinoma. So it's no longer used in clinical use, though we use it quite frequently in the labs. Or also, you may also be given to the males. The other estrogens are phenolic compounds. A number of them are typically found in a plastic. So for example, bisphenol A, which is usually abbreviated as BPA. And you normally find, for example, when you are purchasing baby feeding bottles, that they indicate that whether there's BPA positive, BPA negative. If it's BPA negative, then they have eliminated BPA, which has estrogenic activity, and therefore many parents will not like their children, particularly boys, consuming high amounts of estrogenic compounds. So the BPA is found in many plastics, including the ones we commonly use for water. Then we now turn our attention to the biosynthesis and secretion of estrogens. So the estrogens are mainly produced in the ovary. And the ovary, as we'll see, is produced mainly in the thicker and the granulose cells. Estrogens are also produced in the placenta, in the quite large amounts in the placenta during pregnancy. Some amounts of estrogen are produced in the adrenal cortex of both the males and the females, and in the testes, as well as other tissues with aromatase activity, for example, within the adipose tissue. The biosynthesis pathway of estrogen begin really from cholesterol. The first step in the biosynthesis of estrogens is cholesterol. So cholesterol that is derived either from HDL or LDL is then transported into the ovary. And the first step, which is the rate limiting step, is the conversion of cholesterol into pregnenolone. And that step is catalyzed by an enzyme known as steroid desmolase, or the cytochrome P450 side chain cleavage system. From pregnenolone, the pathway branches into two. One of the pathways proceeds through progesterone all the way to androstenedione. So I don't know if you can see my cursor. So pregnenolone all the way to, passing through progesterone to androstenedione. That's one of the pathways. The other pathway proceeds through pregnenolone, going there to the left, to hydroxypregnenolone, passing through dehydroepiandrosterone, commonly abbreviated as DHEA, and eventually to androstenedione. Androstenedione is then converted into testosterone, and testosterone is converted to estradiol through the action of an enzyme called aromatase. Androsterone may also be converted into estrone through the action of aromatase. So androstenedione and testosterone are androgens. We shall look at them, and they are precursors of the estrogens. We shall also look at the role of aromatase quite closely in the next session when we are looking at anti-estrogens. So this brings us to what is called the two-cell, two-hormone theory of estrogen production. So according to this theory, the production of estrogen requires two cells and two hormones, just like its name says. The two cells that are required are illustrated here. One is the thicker cell, and the second is the granulose cell. So according to this theory, then luteinizing hormone stimulates the conversion, which we said is the rate limiting step, of cholesterol into androstenedione through those series of steps that we have seen. Androstenedione, an androgen, is then transported across into the granulose cell of the ovary, which under the influence of follicle-stimulating hormone, then it is converted into the estrogens. So estrone and estradiol. So the aromatase enzyme is under the control of follicle-stimulating hormone. So we have two cells there. The thicker cell, which produces the androgens, and secondly, we have granulose cell, which produces the estrogens. The two cells are under the influence of two hormones, one, luteinizing hormone, and second, follicle-stimulating hormone. So that is the two-cell, two-hormone theory or hypothesis of estrogen production in the ovary. We then look at some of the pharmacological and physiological actions of estrogen. In terms of its mechanism of action, estrogen brings about its action by binding to a receptor. This receptor is called estrogen receptor, simply as that. The ER, estrogen binds to estrogen receptor. The estrogen receptor belongs to a superfamily of receptors that include the receptors for other sex steroids. For example, the androgen. So the androgen receptor. It also includes the receptors for other steroids, such as the glucocorticoids and the mineralocorticoids, as well as vitamin D and also the thyroid hormones. So for estrogen, the ER, which is the estrogen receptor, has two isoforms, the ER alpha and the ER beta. The ER alpha is mainly found in the reproductive system of the female as well as in the mammary glands. The ER beta is mainly found in the prostate in the males as well as the ovaries. So how does estrogen bring about its action? We have there an illustration of estrogen. So estrogen is lipophilic or hydrophobic and diffuses across the plasma membrane. It then interacts with the estrogen receptor, which is shown here in green. Upon binding of the estrogen ligand, the estrogen receptor complex will dimerize. They dimerize, and this dimerization can be of estrogen receptor alpha and another estrogen receptor alpha, which is called homodimerization, or it can be heterodimerization of estrogen receptor alpha and estrogen receptor beta. The estrogen receptor dimer then binds to the DNA, and the section of the DNA that it binds to is called estrogen response elements, ERE. These estrogen response elements there's a bit of detail that is shown on the left panel there, is a section of the DNA that sits near the promoter of the target sequences that are affected by estrogen. And that, say, the ERE is arranged in a specific way. So we normally define that ERE as being arranged as a palindrome. That is, the sequence of the nucleotides of the ERE can be read in either way. So a palindrome is a word that can be read either way. Maybe like a word like madam can be read, from left to right or right to left. So they are palindromic sequences. That binding of the estrogen receptor complex on the ERE is also quite complex. It's not very straightforward, as it involves the binding of other molecules, such as shown here, for example, the CBP, which is cyclic AMP response binding elements. Thereafter, then, estrogen will promote the transcription of target genes. So these are hormones whose effects are found in the nucleus through stimulation of transcription of particular genes and eventually translation and biosynthesis of particular proteins. So that is how estrogen works at a molecular level. In terms of its physiological and pharmacological action, we can quickly go through some of the important effects. So estrogen is responsible for the secondary sexual characteristics of the female. So as we mentioned, feminine body configuration, the deposition of fat on breasts, around the thighs and the hips to give the females their particular body type. It is responsible for the maturation of both the external and internal genitalia. It is responsible for the further development of the vulva and the vagina. It is responsible for maturation of the uterus and the enlargement of the uterus, the hypertrophy of the cervix, and the further development of the breasts. On blood, estrogen increases coagulation by increasing the activities of factor 2, 7, 9, and 10, and also promoting platelet aggregation. It may also have an impact on other factors that suppress coagulation, so therefore some of the effects may depend on the particular circumstances. On the bone and the skeletal system, estrogen stimulates osteoblasts, so it will promote conservation of both calcium ions and conservation, and therefore it increases bone mass, that is, increases the density of the bone, and it will accelerate the fusion of the epiphyses. Estrogen also increases sodium and water retention, and it also lowers LDL and raises HDL, which is a good effect because, LDL is what is called the bad cholesterol. So estrogen increases HDL levels, which is a good effect. We now turn our attention to the pharmacokinetics of estrogens. Estrogens may be given by several routes. It can be given by mouth, orally, though that is not, that's quite a frequent. We'll see that in for example, when you're looking at the hormonal contraceptives, they can be given parenterally, so by injections, can be put on the skin. It can also be given via implants. So in terms of how well is absorbed, orally, that is, the bioavailability is low for the natural hormones because of a very large fast-pass effect. So the liver removes estrogen very fast. So that's why, for example, you don't give estradiol, but we give if you still remember, the synthetic steroidal estrogens, for example, ethinyl estradiol, okay? But bioavailability through the skin is quite high. Estrogen is well distributed in the body, particularly to the liver, the adipose tissue, the female genital system, to the breast, and in the brain, and it binds to a specific protein, which is an alpha-2 globulin. It is metabolized in the liver. Estrogens are metabolized in the liver. As we've said, this is very fast and rapid for natural hormones such as the estradiol, estron, and estriol. And there's also enterohepatic circulation. So this means that estrogens, upon absorption, are transported to the liver, as shown in this chart, transported to the liver. In the liver, they are conjugated and then passed through to the gut. And in the gut, the conjugated estrogens are deconjugated by the gut bacteria and then reabsorbed into the circulation. And this is a very important system because if you administer estrogens concurrently with antibiotics, especially broad spectrum antibiotics, what happens is that the broad spectrum antibiotics will eliminate the gut microbiome, and the eventual effect is that the hormones are not deconjugated, and therefore they pass through the stool, and therefore you have low levels. And that's why we say that the antibiotics will reduce the efficacy or effectiveness of estrogens because they eliminate the gut microbiome that are responsible for deconjugating and therefore for maintaining the levels of the estrogens in the bloodstream. From there, then we shift and look at some of the therapeutic applications of the estrogens. These are a number, but very quickly, one of the important applications is hormone replacement therapy, particularly post-menopausal hormone replacement, HRT. And this, of course, post-menopause, there is a reduction, a severe reduction in the levels of estrogen, and therefore some of the very good effects of estrogen that we've seen are lost, and therefore postmenopausal hormone replacement therapy affords relief from hot flashes, sweating, and insomnia. It also decreases atrophic changes of the vagina and also reduces bone fracture because estrogen increases bone mass. Estrogens are also popularly used for hormonal contraception. We'll see that in the next, I think the session after the next, and can also be used in hormone replacement therapy. For example, in hypogonadotropic gonadonism, that is where you have low levels of GnRH and also eventually low levels of estrogens coming from the ovaries. So the estrogens may be given. So some other uses of estrogen include in atrophic vaginitis, we've seen the good effects of estrogen on the thickening of the vagina and development of, as well, of the vulva. It can be used for dysmenorrhea and menorrhagia. It can be used in amenorrhea. We'll see some of how that works in the next subsequent lectures. It can be used in managing hirsutism and prostate cancer in the males. Some of the possible adverse effects include causing postmenopausal uterine bleeding, and this is because of the effect of estrogen on the endometrium. In the previous session, we saw that estrogen causes proliferation of the endometrium, and therefore post-menopause, you may see postmenopausal uterine bleeding. It can cause nausea and breast tenderness because of the effects also on the breast. Cholestasis and gallbladder disease, we've seen how it is metabolized by the liver, and then the enterohepatic circulation may cause anorexia. Salt and water retention, we have seen that in the effects of estrogen, increased risk of thromboembolism, endometrial hyperplasia, because we have seen these effects of estrogen previously. So this can also be adverse effects and feminization of the males. Estrogen is contraindicated in estrogen-dependent cancers. We'll see that also in the next session, how anti-estrogens may be used in estrogen-dependent cancers. In endometriosis, which is the presence of endometrial tissue in places other than the uterus lining where it's supposed to be. It's contraindicated in liver disease, gallbladder disease. All these are predictable from the pharmacology that we have seen, and diagnosed vaginal bleeding, because we have also seen the effect of estrogen on the endometrium, and therefore possible effects on, as a possible effect on promoting especially postmenopausal uterine bleeding. In someone with a history of thromboembolic disorders, we looked at the impact of estrogen on blood, in coronary artery disease, migraine, porphyria, and in pregnancy. So those are some of the areas in which estrogens are contraindicated. So to finish, really, we have seen estrogens, we've classified them, we have outlined their biosynthesis, pharmacokinetics, we have reviewed the effect of estrogens, the clinical applications, the adverse effects. So this question that we began with in the beginning, a young adolescent female diagnosed with hypogonadotropic hypogonadism is receiving hormone replacement therapy. Which of the following is a likely effect of the hormone replacement therapy? So A was increased serum LDL, B is low bone mass, C is acceleration of epiphyseal fusion, D is suppression of breast development, and E is hot flashes. Really, the answer there is C, because we have seen that as an effect of estrogen, because HRT here is the eventual impact is to increase estrogen levels. And some of those, for example, A, increased serum LDL, we saw that it actually suppresses. We've seen estrogen increasing the bone mass, so B is really the opposite effect. D, we have seen effect of estrogen in breast development, so it's not going to suppress it. And hot flashes, we have also seen estrogen relieving hot flashes, so that is not an effect of estrogen, the actual opposite. So the answer is actually C. So thank you very much. That's the end of this session. I'll then look at, see whether you have questions in our Q&A session. Thank you.